Hi, and welcome to AAHPO's American Armenian Health Professional Organization's TV's health program. Oral hygiene and dental health is very important for general health. And today, we have our guest, a general dentist, Dr. Stephen Dadaian, who has general dental practice in Cresskill and has special interest in dental implant. Dr. Dadaian, welcome to our program.
Oh, thank you.
So, I know you have special interest in dental implants.
Right.
What is dental implant?
So dental implants are one of the biggest things in dentistry right now, and essentially the dental implant is a way that patients who may be missing teeth can be given their teeth back. We can restore them. So the implant itself is a titanium screw that we can put in the bone, and it essentially helps us as dentists give back what was lost.
So the dental, you can put the implant there, and then it can be one tooth only, but then you can do some bridges on top of it and connect to other teeth?
Exactly. So the way we think of it is that the dental implant is almost like the root of the tooth, and we can use it to replace one tooth, many teeth.
Right.
A lot of older folks, there's 180 million or so Americans that are missing teeth, and about 35 to 40 million have no teeth of those. And what we can do is we can replace all of them. Some folks that have dentures, traditional dentures, we hear a lot about that. Some favorable, some not so favorable about them. It completely changes the standard of care and their way of life.
Who are the candidates? Anybody can be candidate for dental implant?
Most patients are, and that's the great thing. They're very successful, over 95% successful when done properly. And really any patients that are missing teeth, as long as they have the bone support for it and medically healthy, they usually can.
There are medical conditions that probably those people will not be candidate for dental implants. What conditions that you would say to the patient that you might not be the candidate?
Right, and this is a great thing that, and why I love always discussing with their general physician as well, because some of the things we look at are type 2 diabetes, patients that just have uncontrolled diabetes, certain conditions such as periodontal disease, uncontrolled, systemic health illnesses may preclude them. Good thing is certain things that you may think preclude someone, like osteoporosis, a bone disease, is actually not necessarily a contraindication. Right.
So if they're on osteoporosis treatment, is there any problem for dental implant?
That's a good question, because with any surgery, if they're taking IV medication, certain drugs like Zometa, they may be on. Actually, we have to be careful, because whenever we do a surgery and they're on certain types of osteoporosis medication,
which is their osteoblastic medication, we call
correct,
to regenerate the bone.
Right. Sometimes the soft tissue, meaning the gums, don't always heal that well, and sometimes we get areas where the gums don't heal 100%, and that can compromise the implant. So we always have to be careful, and that's why we always, as a general dentist, I'm always discussing with their physician, their medical doctor, back and forth. Can we do this? Can we not do this? We just want to do what's best for the patient.
Right. So let's say most of the time now we start with osteoporosis medication, and then after a while we stop the medication. Because we say it's enough. From osteoporosis they can go to osteopenia or even better situation.
Correct.
So do you wait until they complete the treatment? Or it can be done during the course of the treatment?
Usually with oral medications, it's usually okay. With IV medication, we take some more precautions, so we may wait a little bit longer. In general, the benefit of the osteoporosis medication outweighs the implant usually. So we'll always have them stay on, if we have to choose one or the other, because there are non-surgical means of restoring teeth back to the way they were. Implants are just the standard of care now. So
let's go the process of implant.
Right.
Let's start from the beginning. Let's say a patient comes in and he or she is candidate for implant. What is first?
That's great. So first thing we have to do is, of course, make sure medically they're healthy. Once we've established that they are medically a good candidate, we have to look inside the mouth. So certain parts of the mouth have higher chances of success than others, merely because the bone in certain parts of the mouth is more dense. It's harder. Right. So we look at that. We want to see how much bone do they have. Do they have good hygiene? Will they be compliant? We look at these things. So what we'll do is we'll take usually an X-ray. We want to see also, because we don't have X-ray vision, we don't have superpowers, we have to look and we have to see. So once we establish those things, what your general dentist will do, if your dentist is the one placing the implants, they may want a surgeon to do that. What they'll do is they'll maybe take an impression, they'll maybe make models so we can study what they look like. We won't have them there all the time. Right? So we'll look at these things, and we'll make a treatment plan for them. We'll outline for them typically how many they need, what the anticipated time will be. The surgeon or the dentist will place the implant. Typically, we'll wait about 3 months healing time.
You implant the base first?
Exactly.
In the bone?
Yes.
In the mandible or jawbone?
Or upper, yes.
Or upper. And there's a base there?
Correct.
And then after that base?
So that base will stay usually submerged under the gums for about 3 months.
Right. So there's a waiting process for 3 months?
Yes. It used to be longer, but with the more current scientific knowledge now, we know that we don't need quite that long.
Right.
And it depends. So on average, and this is assuming they don't need any additional procedures, is about 3 months. After the 3 months, we go back in and we can take an impression of that area.
Right.
And then it will take roughly around 2 weeks for a lab to typically fabricate a crown or bridge or whatever prosthesis they're getting. For more teeth, obviously, it'll take a little bit longer time and more visits, but for the most common procedure that we see as dentists is a lower first molar, and which is a single tooth. So for a single tooth, that would typically be the time frame around 3.5 to 4 months from start to finish, and that can last for a very, very long time.
What is the difference between regular tooth and this implant tooth?
That's right. They're not the same thing. The implants don't behave like a natural tooth. Although they do fill the space and they have very many benefits, there are differences. So we have to remember that with these implants, they're integrated into the bone. There's no space, there's no fibers holding it in place. It's man-made, right? So we have to be aware that with these, when we get a cleaning done, that their general dentist should know when they're doing the cleaning, certain instruments we can't use near there. We have to take special precautions.
For that dental implant.
Exactly. There are other benefits in that it's metal. So typically bacteria that would eat away at a tooth won't eat away at the implant itself, but it can compromise the bed that it's sitting in. So we just have to take certain precautions with the implant that we wouldn't take with the natural tooth and vice versa.
How long an implant lasts? It's not forever, I'm sure.
It's not.
Time period for that?
Right. You know, they can last, assuming all of the other parameters we mentioned stay the same, healthy and this and that. You know, there's no real time frame as to when we would say, okay, this is going to fail. A typical crown in the United States on a natural tooth will last anywhere from 7 to 10 years. That's the average. In our office, you know, we've seen much longer than that, but that's just the national average. So assuming the patient takes care of the crown, the implant, they go for regular visits, there's no reason why they should lose it. And it's also the same reason why if patients are seeing their dentist every 6 months, there's no real reason why they should have periodontal disease or be losing teeth. Sure, there are genetic factors that come into play.
If there's an implant in place, is there any different recommendation for follow-ups? Let's say I go to my dentist every 6 months.
Correct.
For general check.
Right.
Is there any difference for if I have the implants?
So
in terms of the time?
The time frame usually is the same, but we may want to take care of it differently from our perspective. So there are a couple of things we'll look at, and I think that's one of them. I would look at that way.
Is there any particular toothpaste or toothbrush that they should use?
Right.
Is there any difference?
Exactly. I see a lot of this is a concern for patients too, because a lot of people think that, okay, well, if I want to clean my teeth, I want to brush really hard, and that's going to make them cleaner. It's not so. We always recommend a soft bristle brush, especially around the implants, because you know, it is a gentle area. So we always recommend a soft bristle brush, and as long as the toothpaste they're using contains fluoride in it, they're almost all good. Whether it's Colgate, Crest, Tom's of Maine,
as long as there's a
fluoride is the active ingredient. There's no real science to suggest that one is better than the other. And if they have the manual dexterity to use a regular brush as opposed to an electronic one, then that's totally fine too.
What kind of complication they can expect with an implant?
So the thing with the complications is that they typically happen relatively soon after the implant if they're going to have it. So if they've had the implant for about a year already, they're usually in the clear. They don't have to worry. The implants fail for 2 reasons. One is if the crown is too high. When they bite down, it feels high. We call that occlusal overload. Essentially, that height of the crown over time will weaken it.
I see.
That's one. The other is called peri-implantitis. This is an illness where the area around the implant gets infected. Almost
the base, probably.
Correct. Sometimes it doesn't integrate. Sometimes when they do the surgery, maybe they didn't use enough water, maybe the bone got too hot, it can necrose. So it won't ever really form tightly around it. So we can get that, and sometimes even when they have the cement on the crown, when they glue it in, sometimes the dentist can use too much. And over time, that cement is a foreign body inside of us.
Right.
The body says, hey, wait a minute, this cement doesn't belong here. And it tries to get rid of it, inflammation, like it would anything in the body, any foreign body, and it causes the bone to go away, and they'll fail. So we look at these two things, and usually it'll fail for one of those two reasons.
Right.
But if they've made it about a year or so after the surgery and no problems with their crown on, they're usually okay. Yeah.
So what is the next 10 years for implants?
Implants are such a hot topic now, right? And at first they were very expensive.
Right.
They're still they're becoming more affordable now. Where I see implants going is that most of them are made out of titanium. There are some implants that are being marketed made out of different materials, like zirconia, which is a biocompatible material. There's usually no sort of allergic reaction to it in the body.
There's some companies that they are doing 3D production of the implant.
Right. I think there's really amazing technology happening now that's crossing over into dentistry. 3D printing is one of them. One of the weak parts of the implant is that there's a separate screw that keeps the crown in sometimes, or the abutment. Some of them, I think they're trying to avoid that. So I think some of the technical design flaws of the implant we're overcoming, and even people are out of stem cells making in petri dishes teeth.
Yeah.
So who knows? In 10 years, 15 years, just as medicine's evolving very rapidly, there's a lot of cool stuff happening in dentistry right now, so we'll just have to see where that goes.
Dr. Dadaian, thank you very much for your enlightening
information. It was a pleasure.
information.
Thank you so much.
Now it's time for this week's article, and it is about obesity, diabetes, and chance of liver cancer. Rates of liver cancer have tripled in the U.S. since 1970s. Studies suggest that people with fatty liver disease have a risk of liver cancer that is 4 times higher than people without this condition. 1 in 5 of us are already likely to have this condition. 2 major risk factors for this are being 1, obese and or having type 2 diabetes. U.S. researchers investigated whether obesity might be linked to liver cancer. They used body mass index and waist circumference measurements as a marker for belly fat and type 2 diabetes, which is usually associated with being obese. The researchers compared the rates of liver cancer among participants with or without obesity and type 2 diabetes to determine how much of these factors could be behind developing liver cancer. What they found was that every 5 points increase in body mass index, there was 38% increase in the risk of liver cancer among men and 25% increase among women. The risk of getting liver cancer increased around 8% for every 2-inch increase in waist circumference. Those with type 2 diabetes were 2.6 times more likely to be diagnosed with liver cancer. Normal waist circumference is 32 inches and less for women and 37 inches and less for men, and it's measured around belly button. If you have large abdomen and body mass index is more than 25, try to lose your excess body fat by exercising regularly and decreasing your sugar and caloric intake in order to decrease the chance of getting fatty liver disease and liver cancer. Good health is precious and priceless. Keep up to date. Visit AAHPO's website, AAHPO.org, for up-to-date information. I'm Dr. Ohan Karatoprak. Until next program, so long.